Give me a head. I'll just start by several disclosures. One disclosure is that I'm not going to talk about exactly what was advertised. What I'm going to do is try to present you with a perspective on how I talk to patients when they have atrial fibrillation. I do have some honoraria and research support to disclose from all the companies that manufacture novel oral anticoagulants, which we will mention only briefly, since what I'd like to do, with your permission, is really just give you an overview of how I talk to patients when they have this condition. So my general approach to atrial fibrillation is I first start asking myself a number of questions with every patient that I see in the office. It doesn't take long to answer these questions, but I think this is a worthwhile exercise. So the first question is, has atrial fibrillation been documented? Not all palpitations, as obviously you will know, are necessarily atrial fibrillation. So it's the most common cardiac arrhythmia, but we do need to document it electrocardiographically. Very importantly, in a patient who has atrial fibrillation, I try to be certain before I embark on therapy whether their symptoms are in fact caused by atrial fibrillation. It won't surprise you to know that the average 75-year-old with atrial fibrillation often has coexisting disorders: hypertension, diabetes, coronary disease, heart failure, osteoporosis, COPD, alcohol abuse, etc., and many of those things are deconditioning, and many of those conditions cause dyspnea, fatigue. In fact, I'm mostly dyspneic and fatigued most of the time. If you ask my children, I'm also not very smart. And so many of you find that many of your patients are often dyspneic and fatigued, and it may have nothing to do with their atrial fibrillation. And if you treat their atrial fibrillation, for example, with beta blockers, you'll make your patients more dyspneic and more fatigued, if indeed the symptoms are caused by something else. I ask myself, and this is very important in my practice, and we'll come back to this in just a few minutes, whether the pattern of atrial fibrillation is that which we call paroxysmal, which means that atrial fibrillation will stop on its own if you do nothing. That happens to most of the patients most of the time, particularly in younger patients. Less true in patients where it's discovered in their 80s or 90s, for example. So if a patient's pattern is, take the average 68-year-old with atrial fibrillation, they develop palpitations, they last a few hours, and then they go away. If you give those patients strychnine or castor oil or aspirin, the atrial fibrillation will go away. You do not have to give them an antiarrhythmic drug. And what happens is often these patients come to the belief that they need to go to the hospital, they need to have an emergency room visits, they need to have an electrical cardioversion, they need antiarrhythmic drugs in order to get the rhythm stopped. And they end up on a treadmill, so to speak, that every time they get the condition, they get a treatment, the AFib goes away. It was going to go away on its own anyway, and then they are then convinced of the belief, and their physicians are convinced of the belief, that every time they get AFib, then it needs immediate treatment, which of course it does not if it's going to stop on its own. Other patients have so-called persistent atrial fibrillation, which is AFib, which will not stop on its own. And in them, if you want to get it stopped, then they do need antiarrhythmic therapies or electrical cardioversion. The next question I ask myself is, was there something that made the atrial fibrillation start either on this particular occasion or in general? The most common acute precipitant of atrial fibrillation, which by the way is not that common. Most of the time it happens because it's Tuesday, no specific reason. It's a random event in my opinion. But there are causes that I think you're all familiar with: acute illnesses like pneumonia, acute heart failure, coronary events infrequently cause atrial fibrillation, and particularly alcohol excess. We'll come back to alcohol in a minute. I'm a strong believer in alcohol. The more the better, up to a particular limit, above which atrial fibrillation will be more likely to occur, but not with ordinary amounts. But that would be a reversible cause. This is probably the most important slide, and I'm going to come back to this in my final slide. In my opinion, the main missing link in the way that we deal with patients with atrial fibrillation is not lack of knowledge about anticoagulation or stroke prevention or rate control or rhythm control. It's the fact that our patients get a ton of information. Most of it is misinformation from the internet, or they get incomplete information from their caregivers. And the consequence is that their quality of life, which is often impaired anyway, is even more impaired than it would be otherwise, because they have the perception that atrial fibrillation is a life-threatening disorder, it's going to cause heart attack, it's going to cause a stroke, and they will die. Very important for us to keep in mind that the only reason, there's actually, I take that back, there's two reasons to treat atrial fibrillation. The first and most important reason is to improve patients' quality of life. If their quality of life is good to begin with, there's no reason to treat atrial fibrillation directly. The second reason is to prevent stroke, which is unrelated to the quality of life. So you can have asymptomatic atrial fibrillation, as we all know, with no impairment of quality of life, and the patients are still at risk for stroke, and we have stroke prevention therapies, which we'll mention very briefly. But the first thing I think about is, and I ask the patients directly, explicitly, Mr. Smith, Mrs. Jones, whatever the name is, how much does this condition affect your quality of life? And all of my therapeutic interventions are based on the patient's perception, not my perception, of how much the condition is bothering them. Included in that, of course, is their values and preferences. Some patients are very athletic and they want to go skiing and they want to travel, and for them they are more invested in getting rid of all of their atrial fibrillation than other patients in whom these things are sort of less salient. Most patients, if they consult the internet or they ask their neighbors, I play a lot of tennis, and in my tennis club there's a lot of people around my age or older, and I never get out of the change room without being interrupted while I'm wearing a towel and being asked about atrial fibrillation. The ladies stop me in the hallway, by the way, not in the change room, but I get asked all the time, what should I do about my atrial fibrillation? And the typical questions I get from patients and from friends and from colleagues and from neighbors and from aunts and uncles is, can I drink coffee? Most people believe that caffeine causes AFib. This is incorrect. If anything, caffeine prevents atrial fibrillation. Large meta-analyses suggest that coffee drinkers get AFib less often than non-coffee drinkers. I'm not sure I'd recommend caffeine as a cure, but it certainly is not harmful. Stress does not cause atrial fibrillation. Atrial fibrillation can cause patients to be stressed, but there's no relationship to stress. There's no relationship in almost all patients to exercise, with very rare exceptions. Occasional patients will tell you every time they work out or they go jogging or they do some form of strenuous exercise, or some of the time they'll get atrial fibrillation, but in most patients, most of the time the episodes come on at rest, and it's part of our task to persuade patients to exercise, which in fact is protective, with rare exceptions. Alcohol in moderation is permitted. I make patients very, very happy when I tell them that. In moderation usually is defined as no more than 2 or 3 standard drinks a day for men and 1 to 2 standard drinks a day for women. So obviously a lot of alcohol is not a good idea, but small amounts of alcohol are permitted and in my practice strongly encouraged. That's provided they drink already. I don't tell patients to start drinking just because of me, although that wouldn't be such a bad idea either. I also spend quite a bit of time telling patients that when they get atrial fibrillation, they should not go to hospital unless they're so dizzy they can't stand up, or they have symptoms of overt heart failure, or they have symptoms of myocardial ischemia, so severe chest pain. If they have a bit of chest discomfort, you sort of have to use your judgment, but most of the patients, we're talking 98% or so, 99% of patients with atrial fibrillation are not having angina, they are not having an infarct, and they are not having heart failure, and they will not have a stroke in the next 5 minutes. And this is a condition that we take seriously, but you can treat as an outpatient. So emergency room visits for most of the patients are not necessary. And when the patients, as I said, get on a treadmill, and every time they get AFib, they run to the emerge, they end up going to the emergency room. Emergency physicians understandably want to treat them aggressively because that's kind of what they do, but it's not absolutely necessary. What are some of the things that I think about that I need to take sort of seriously that is sort of unrelated to the atrial fibrillation itself, but maybe underlying causes? These are the largest ticket items in my experience that we sometimes sort of overlook as a community in patients with atrial fibrillation. I'll say quite a bit more about hypertension in a second. You can be confident that somewhere between 70 and 80% of all your patients with AFib have hypertension. Most of them will have been diagnosed, but some of them will have not yet been diagnosed. Think of atrial fibrillation as end organ damage caused by hypertension in the majority of patients. Just like renal disease is end organ damage caused by diabetes in most patients with diabetes. You can get renal disease, of course, from other causes as well. Obesity and sleep apnea, we all know about. We don't have to belabor that, but they're common, and commonly obesity is hard to overlook, but sleep apnea can be easily overlooked. The prevalence of sleep apnea in patients under the age of 75 with AFib is somewhere between 50 and 70%, even if patients don't snore and even if patients don't fall asleep during the daytime, for example. A small print item is patients who engage in lifelong competitive exercise, the kind of patients that you might see in your practice who run marathons or in triathlons. Usually these are people who train 1 to 2 hours every single day. There's not many of them. They're understandably upset when they get AFib because it interferes with their training and their competition. And as I mentioned, episodic alcohol excess, emphasis being excess. Let's talk a little bit about hypertension. Let's see if the pointer works here. Maybe I'll get the pointer working or not. Here we have the pointer. I apologize for those of you at the very back who have trouble seeing this. This is the relationship between blood pressure and the probability of developing atrial fibrillation. Only to remind us, when patients are young, as the pressure goes up, the incidence of atrial fibrillation goes up very dramatically. In the elderly, if you're over 80 years old, it really doesn't matter what your blood pressure is. Your probability of developing atrial fibrillation, of course, much higher. The overall incidence is on the y-axis. So there's no relationship in the elderly between ambient or prevalent blood pressure and the incidence of atrial fibrillation, and it's of course much higher than younger patients. But in most of your patients under the age of 70, there is a relationship between blood pressure and the probability of developing atrial fibrillation. Now, once you have high blood pressure, it's very important to control it. This is just one example amongst many. This is from a study in Japan called the J-Rhythm study. Basically, what this tells us is, let's just focus on these 2 bars over here. In the patients with a systolic pressure at clinic visits of more than 136, this is divided into quartiles, which is why these odd numbers. And the patients are not anticoagulated, the risk of stroke is very high. If they are anticoagulated, the risk of stroke is still quite a bit higher than the risk of stroke in patients. All of the patients in the pale blue here are indeed treated with warfarin. We have similar data with NOACs, not quite as good, so that hypertension by itself, defined here arbitrarily as upper quartile, more than 136 systolic, more risk of stroke by a large amount than in patients who have less hypertension, even though they're all treated with anticoagulants. And if you're on an anticoagulant and your blood pressure is less well controlled, you have a much higher risk of hemorrhage. So hypertension increases the risk of bleeding and increases the risk of stroke with or without the presence of anticoagulants. Now, does treating hypertension aggressively reduce the risk of developing atrial fibrillation? The data is a little bit incomplete or uncertain. This is from a large meta-analysis. The answer is, in general, yes. The effect is relatively small because by the time patients get into the hypertension trials, they've often been hypertensive for a long time. The atrium's already suffered the damage. Just imagine enrolling a whole bunch of diabetics in a large trial where they already all have kidney disease. You're not going to necessarily have much effect on reversing kidney disease by treating the diabetes more effectively. You can prevent progression, but you can't reverse it easily. Similarly, you can't reverse very easily atrial fibrillation, but you can prevent the worsening of the condition, if you like, by treating atrial fibrillation aggressively. You can see at the bottom under event rate, the little blank diamond shows us that there's a reduction in the incidence of atrial fibrillation with aggressively treated hypertension. So what lifestyle advice can we give patients? The lifestyle advice is easy. Following lifestyle is very hard. But just to kind of remind us that the group in Adelaide, Australia, led by Prash Santers, has done some excellent work, and they have 3 trials. We'll go quickly here. Bottom line is diet and exercise work for AFib, just like they work for many things, provided they can be achieved. This is a legacy study. What they looked at was weight loss in patients who all had either overweight or obesity. Average weight loss was about 10% in these trials. In red is the control group. In pale blue is the group that lost less than 10% of their total body weight. And in dark blue, in the darkest blue is patients who didn't lose weight at all. In red is patients who lost weight. I apologize. So what you see here is that the more weight you lose, the less the probability of atrial fibrillation recurrence, both symptomatic and asymptomatic recurrence. So that's weight loss. If you do this after an ablation procedure, which is a surgical treatment, it works much better if you combine that with weight loss in the red, and it works much less well if you don't combine it with weight loss in the pale blue. 50% recurrence rates with no weight loss, 10% recurrence with weight loss. And if you have weight loss plus exercise, you do much better. So in dark red is both weight loss and exercise. In the palest blue, the worst outcomes are neither weight loss or exercise. So if you manage to increase your fitness level or you manage to lose weight, you get an intermediate result. This is recurrences of symptomatic atrial fibrillation in relatively unfit, obese, or overweight patients. So both weight loss and exercise are very effective. And unlike weight loss and exercise, it seems to me, in many patients that you see in the office where there may be cosmetic or fear of future event reasons to lose weight, here there's an immediate, if you can tell the patients, there's immediate incentive to lose weight and exercise. When you tell them, the chances are very good that if the patient manages to do that, they're going to feel better, they'll have less palpitations, less atrial fibrillation, and in my experience, that's been a pretty good incentive. Doesn't always work, but certainly something you can mention. Now, we know that diet has only limited capacity. If you're a politician, Bernard Shaw reminded us, no diet will remove all the fat from your body because the brain is entirely fat. Without a brain, you might look good, but all you could do is run for public office. And I'm sure you have many individuals, specific individuals in mind, and we won't go there. Okay, traditionally, and I'm going to try to finish pretty quickly here, traditionally, let's get on to rate and rhythm. And I advertise this is going to be quick because I don't have a lot to tell you except we have to treat the patient and not the arrhythmia. This is what we've done traditionally for decades when we talked about AFib. We talked about preventing stroke. We'll come back to that. We talked about rate control and rhythm control. I'm going to suggest that we should forget that. We should think about, not completely forget it, but it's of minor importance. Why? Because it's not about the rate and the rhythm. It's about how the patient feels. So our primary goal, or one of our primary goals, is reducing cardiovascular morbidity and mortality. Treating AFib per se will not reduce morbidity and mortality. There's no evidence that getting rid of AFib will make the patient live longer, none whatsoever, by any means. But of course, if the patient's diabetic, hypertensive, has heart failure, we want to treat the underlying conditions, which themselves cause increased mortality, and treating those conditions will decrease mortality. So you have to pay attention to the patient and their cardiovascular risk. But by itself, treating AFib will not prolong mortality, at least not that's been proven. We want to prevent stroke, we'll come back to that, and we want to treat symptoms. And treating symptoms, half of it is rate and rhythm, and the other half is psychotherapy. We'll come back to that. So one way of looking at it is the way the Europeans look at it. These two slides are a bit complicated, but this one just reminds us that you want to know whether the AFib is persistent or paroxysmal, and then you want to impose treatments or recommend treatments depending on the pattern of atrial fibrillation. This is a complicated slide, but basically it leads us through. This is just, let's walk through it as an exercise in sort of thinking process. We generally first start in symptomatic patients that are aware of rapid irregular heartbeats, palpitations, feeling their hearts going quickly, short of breath. And we first start by slowing the rate during atrial fibrillation. The general target is less than 100 beats per minute at rest. That's an empiric target. There's not great science. We do not need to get the heart rate down to the normal value, 60 or 70 beats per minute. There's some data that it's sufficient to get the resting heart rate down to less than 100 if the patient is asymptomatic. If the patient still has symptoms, they're bothered by their atrial fibrillation, then we think about rate control, which would either be antiarrhythmic drugs or radiofrequency ablation, and that's generally the province of a cardiologist or an electrophysiologist, particularly ablation, which is a surgical procedure to try to get rid of AFib. Doesn't always work, moderately effective, has some non-trivial risks, and it is useful, but only in selected cases. So if the patient's got paroxysms of AFib, then we give medications, because we don't have to cardiovert them. They're going to cardiovert spontaneously. If the patient has persistent AFib, then first we have to get the patients into sinus rhythm, which we do that with cardioversion. And then in many cases, we then have to add medications to prevent the atrial fibrillation from recurring. A strategy that I use frequently with patients when they have paroxysmal atrial fibrillation, which will stop on its own, is to get them to take one single tablet of metoprolol, because it's a rapidly acting beta blocker, when they have palpitations. They can do this anywhere, on a plane, at home, while camping, doesn't matter where they are. It's very safe. They take the medication, they feel better, It works reasonably well. They won't feel perfect. They'll feel better. And we wait until the arrhythmia stops. And if somebody has AFib once a week or once a month, this may be perfectly adequate as therapy, provided that you explain to them that the condition is like a migraine. It's unpleasant when it occurs, but it doesn't have any long-term consequences. The pill in the pocket with antiarrhythmic therapy is something that we generally reserve for the province of cardiologists with an interest in rhythm disturbances, because there's side effects, there's risks, there's sort of very specific strategies, but it is something that's available for select patients. That's 2 more slides. One is on stroke prevention. The bottom line is almost all of your patients with AFib will need medication for stroke prevention. Probably 90% of them have an indication for stroke prevention, either because they're over age 65 or because they have a risk factor for stroke in addition to the AFib. Their stroke risk is going to be 1.5 or 2% per year or more. This is an annual risk. So the 10-year stroke risk in a 65-year-old is 20%. In anybody with hypertension, diabetes, etc., their 10-year stroke risk is probably higher than that. We know that anticoagulants are effective at preventing stroke. And the bottom line is that the newer oral anticoagulants, the so-called direct-acting oral anticoagulants, as compared to warfarin, which we know works much better than placebo, this is now comparing the anticoagulants to already effective therapy, which is warfarin. It's better, it's safer, and it's associated with less mortality and less brain hemorrhage, which are the most serious complications of anticoagulation. So I don't think I need to belabor that. If you have any treatment or group of treatments which compared to the standard of care, which for decades has been warfarin, leads to less death, less disability, and less stroke, then I think that's going to be a good thing, and we don't have to belabor that. So this is my last slide. When I see a patient with atrial fibrillation, this is the concept that I keep in my mind. What we have at the top left-hand corner is the AFib burden. And I've got a dashed line because the relationship between the amount of atrial fibrillation and the patient's symptoms is variable and it's incomplete. Many patients have a lot of AFib and 0 symptoms. Other patients have AFib once a year, lasting 6 hours, and they're totally discombobulated because they're afraid of the consequences. So I don't look so much at the AFib burden. I ask myself, what are the symptoms of this particular patient, which could be related to their AFib or related even to their treatment? I'm also aware of the fact that there's a very complicated and important component of their quality of life, which is determined by their emotional state with respect to AFib. AFib causes anxiety, and if your patients go to the internet, they'll get way more anxious after they have consulted the internet, because the internet will seem to say, if you have AFib, you're going to die, you're going to have a heart attack, your life is over. That's what patients come away with. And I spent a lot of time in my clinic dissuading patients from that concept. So anxiety doesn't directly cause AFib, but AFib causes anxiety, which in turn makes their AFib symptoms worse. So the right-hand part, the AFib psychology, we can treat with discussion, reassurance, tender, loving care. The AFib symptoms we treat with medications and with ablation. And those two are both important to quality of life. So we have to remember the right-hand side, because that's not medications, that's just conversation and reassurance. And with that, I'll stop. Thank you very much.